All righty. Good morning, and hello everyone. Appreciate everyone dialing in to share another webinar hour with the Scleroderma Research Foundation. I'm Luke Evnan, a scleroderma patient and the chairman of the Scleroderma Research Foundation Board of Directors. Today, I join our webinar as the moderator. I'm in San Francisco, and I am really looking forward to having a terrific presentation from Dr. Roham Zamanian, who is webcasting in from just down the peninsula from us at Stanford University. This is the 7th in our webinar series, and whether this is the first or the 7th session that you've attended, please let us know that all the previous presentations can be viewed on our website at sclerodermaresearch, all one word, .org. On the website, we offer a wealth of information. It's all free so that you can be better informed about what's going on the research front and, in addition, what's happening on the treatment front and across the scleroderma community. As an aside, it is very important to us that we're delivering the content that you want. So please share your thoughts by sending a comment via email or by calling the offices. Of course, we also appreciate your support. As we've said, medical research is very time-consuming and also very expensive. We rely exclusively on our donors to speed progress toward a cure. So please, consider making a donation after the presentation today. And also, in that context, I'd like to make a short reference to my chairman's challenge. You can read about it on the website, but here's the bottom line. Deanne, my wife and Scleroderma Research Foundation board member, and I are going to match dollar for dollar from now until the November 12th, every gift that gets made up to $25,000. So hopefully that provides some additional incentive for you to make a contribution today. What we believe is the best way to help patients is to fund and facilitate the most promising research, and we could not do this without you. I'd also like to mention that today's webinar is made possible by generous grants from Gilead Sciences and MedImmune. The webinar today will focus on one of the most life-threatening complications of scleroderma, pulmonary arterial hypertension. We'll explore how the symptom affects our lungs and what is being done to manage it, and what lies ahead from a treatment standpoint. We're scheduled for about an hour together, and within that time we will include a session for question and answers. Questions can be asked by using the chat box in the conference window. Please remember, though, that our webinars are for general information only, and accordingly, no information provided is to be considered personalized medical advice. It's great to have you with us, and my pleasure to introduce one of the nation's leading experts in pulmonary hypertension, as well as an invaluable colleague to everyone in the research community. Dr. Roham Zamanian is director of the Adult Pulmonary Hypertension Clinic Service at Stanford Hospital and Clinics. He is also assistant professor of medicine at the Stanford School of Medicine. His career has focused on translational and clinical research relating to pulmonary vascular diseases with a specific focus on PAH, short for pulmonary arterial hypertension. As a faculty member of Stanford's Vera Moulton Wall Center for Pulmonary Vascular Disease, he is dedicated to growing the translational capacity of the program and has developed the Stanford Pulmonary Hypertension Biobank, as well as leading the effort with multiple enhancements of the Wall Center for Pulmonary Hypertension and building their database there. It's my honor to introduce him today as he presents Pulmonary Hypertension as a Complication of Scleroderma. Roham?
Good morning, Luke. Good morning, everyone. Thank you for the generous introduction. And first and foremost, I would like to thank the Scleroderma Research Foundation for inviting me to give a talk that I think is very important, but also to extend my appreciation to the important work that you do in advancing and advocating for the care of patients with scleroderma. And I'm certainly honored to be with you here today, and honored to be with the colleagues on the line.
Thank you.
My goal today is to talk to you, everyone about pulmonary hypertension as a fatal complication of scleroderma, and make it a guide for patients and caregivers. Essentially, what we'll be covering here today is an overview. What is pulmonary hypertension? How is it diagnosed? How can I, as a physician, treat it? And how should you, as a patient, expect to feel or be treated with the therapies that we have available? As Luke has already mentioned, the pulmonary complications of systemic sclerosis or scleroderma are life-threatening and definitely need to be addressed. Lung pathology now represents a major, if not the main reason for worsening symptomology and mortality in patients with scleroderma. So what is it about scleroderma, and how does it affect the lung? I'll be also trying my best to really pare down some of the conversations that we have, but the most important thing that we begin in terms of all sorts of lung disease, we want to know what two different ways, or what are the places in the lung that scleroderma can affect. And in general, I like to think of it as compartments. One is what we call the parenchyma, or the tissue of the lung, which is really the meat of the lung where the cells reside and make the lung work. And what happens with scleroderma, what can happen, is fibrosis or scarring of the lung. Another way that scleroderma can affect the lung is affecting the blood vessels of the lungs, and that is where pulmonary hypertension comes in. So before we delve in on what pulmonary hypertension is, I would like to talk to you a little bit about what the heart and the lung structures look like. This is a schematic representing the heart, and here is a cross-section through the heart. The heart has two ventricular chambers, the right ventricle and the left ventricle. These are the pumps of the heart, if you will. And there is collecting chambers, the right atrium and the left atrium. Blood flows into the heart from the head through the vena cava on top, and from the legs and the gut through the inferior vena cava to the collecting chamber in the right atrium. It gets transmitted to the right ventricle, pumped through the pulmonary arteries to the left on this side and then the right on this side. And the lung does its job with the blood that goes through the heart. But blood comes back after it's picked up oxygen to the left atrium, goes to the left ventricle, gets pumped to the rest of our bodies, to the head and to the rest of the body below. Here is a schematic of the lung. As the blood that doesn't have any oxygen leaves the heart, it goes to the pulmonary arteries, the right pulmonary artery here and the left pulmonary artery here. And it travels to different lobes on the right side and the left side. And it goes to the very, very fine structures in the lung called the alveolus. That's where the blood picks up oxygen, and it returns back by the pulmonary veins into the heart, and the heart now has oxygenated blood that goes to the rest of the body. One can think of the heart and the lung as sisters in doing a job, or essentially they're in circuit with each other. One can't function without the other, and stress on one causes stress on the other as well. So here is that schematic together. Here is the right atrium, here is the right ventricle, here is the pulmonary artery again, to the left and the right lungs, and there is the blood that goes to the lung, gets oxygen, comes back to the heart. If there are any problems with the left side of the heart, that blood can back up to the lungs and cause what we call pulmonary edema, or fluid in the lungs. If there's any problems inside the lungs, where there's obstruction of blood flow that goes to the lungs in the pulmonary arteries, the pressure can back up to the right ventricle and make the right ventricle dysfunctional. And that's exactly what happens in pulmonary hypertension. But I hope that this schematic shows how closely these two organs and anatomic structures work together. The next slide represents the pathobiology of pulmonary hypertension itself. This is a cross-section of a pulmonary artery that is normal. It has cells around the blood vessel that behave like muscle, that constrict or dilate as your body needs the pulmonary arteries to constrict and dilate. And it has cells that line the blood vessel itself, called the endothelial cells. This schematic here represents this in two dimensions. What happens in pulmonary hypertension for whatever reason, whether it's exposure to methamphetamine and cocaine, which we know cause pulmonary hypertension, or whether it's the immune system attacking these cells, the endothelial cells, as is thought to happen in scleroderma. There is an injury, there's a disruption of the blood vessel, and that disruption leads to a near complete occlusion of a blood vessel that was very, very large. When this happens, you could imagine all the tiny blood vessels in the lungs getting occluded. That puts a lot of pressure on the right side of the heart, and basically this is a state where we call pulmonary hypertension has occurred. The next slide demonstrates the disease of pulmonary hypertension as it evolves. So it's a disease of the blood vessels of the lungs, but it affects the heart, as I've shown you before. As the blood vessels go from a healthy state, where red blood cells can travel through it with ease, to a state where there is very, very small lumen for the blood vessels to travel by, the heart goes from a compensated state, where it can pump efficiently, to a decompensated abnormal state. Here is a pulmonary hypertension lung that has the right ventricle, as seen here, as I've shown you in the previous schematics, very, very much hypertrophied, meaning that it's really gotten large because of the pressures that is seen for over months and years, from a state where it used to be like this. And what you can see also is that the lumen of the left ventricle, or the collecting chamber where the blood comes back into the heart to the left side, has gotten much, much smaller from a heart that used to be normal to this state. This certainly happens in all forms of pulmonary hypertension, but can especially happen in patients with scleroderma. One of the first questions that I get asked is, how can I be diagnosed with pulmonary hypertension? How do I know that the symptoms that I might have, that we'll talk a little bit about what those symptoms are, that is pulmonary hypertension? Well, I've seen patients who come to their physicians with shortness of breath, which is a symptom of pulmonary hypertension, as well as swelling in the legs, which is also a symptom of pulmonary hypertension. And what they have gotten is an echocardiogram. As you can see here, this is an operator performing an echocardiogram on a patient. And basically what we're trying to do is use a Doppler ultrasound to look at the structures of the heart and see if we find any abnormal findings. The echocardiogram is the most common and the most appropriate diagnostic screening tool, meaning that we can tell whether pulmonary hypertension potentially exists or not. But the problem with the echocardiogram, that is not the most accurate tool. And if you've had a pulmonary hypertension as a diagnosis, as a complication of scleroderma, and have only had an echocardiogram, that is not the correct approach. The echocardiogram gives us a window into the heart that pulmonary hypertension may exist, but it doesn't tell us exactly all that we need. Before I tell you what it is that we do to make the diagnosis of pulmonary hypertension, here are images from a typical echocardiogram. And I don't expect that we're going to become all echocardiographers in an hour's time, but I think it's good to know as a patient what you are seeing in the screen and what the physicians are looking at. This is a 4-chamber view. This is actually looking at the heart that I already showed you upside down. Here is the left ventricle. Here is the left atrium. Here is the right ventricle. Here is the left ventricle. Here is the left atrium. Here is the right ventricle and the right atrium. And here is the EKG strip that the patient's heartbeats can be monitored, and we can see in film format how the heart squeezes. I didn't put a film here, but this is just an image of a normal-looking heart. The left ventricle is large. The right ventricle is small and normal. Here is an echocardiogram of someone with pulmonary hypertension. As I showed you in the schematics before, the right ventricle is very large. The right atrium is also very large because of the high pressures in the lungs. And the left ventricle is squished and small because the right ventricle has really taken over. We're going to go back to our schematic that I showed you in a couple of slides ago and tell you about right heart catheterization. Right heart catheterization is a procedure where a catheter is placed into the heart either from the neck, the right or the left, or from the leg. The catheter is used to go through the chambers of the heart, including the right atrium, the right ventricle, and eventually to the pulmonary artery. And that will give us the most accurate pressures inside of the lung. The diagnosis of pulmonary hypertension at one point in time, at least, requires that a right heart catheterization be performed. It is considered the most accurate measure of what is happening inside of the lungs. This schematic is a little bit odd, but it's attempted to basically demonstrate how the heart catheterization, here is the pulmonary artery catheter going out to the pulmonary arteries here, can actually tell us a lot about two different parts of the heart. Here's the right heart. We can get pressures inside the right heart. But as I was mentioning to you before, here is the left heart. And through the veins, if the left heart has any problems, it can place a lot of pressure onto the lungs. This is the structure of the lung that I mentioned earlier, the alveolus. And we as clinicians, while we can't go to the veins to measure the pressures, we can measure the pressures in the arteries by inflating a balloon and estimating the back pressure that comes back to see us. The reason I mention this, and the reason this is important in scleroderma, is that scleroderma doesn't just affect the lungs alone. There are times where scleroderma affects the meat of the left ventricle, and that abnormality needs to also be diagnosed. And that's why even in scleroderma, it's even more important that a right heart catheterization be performed so accurate numbers are obtained. The next slide is a very technical slide, and I don't think that we need to focus on a lot of the technical details. But essentially, I've placed it here to tell you a little bit about pulmonary artery pressures. When I put a catheter into the lung, the numbers that I look for to make the diagnosis of pulmonary hypertension are based on the average or the mean pulmonary artery pressure numbers. In normal human lungs, the mean pulmonary artery pressure is 15 to 17, no more than 17 for sure. In pulmonary hypertension, the diagnosis is made when the mean pulmonary artery pressure in the lung are more than 25 millimeters of mercury. And the second component of this is that we make the diagnosis of pulmonary arterial hypertension based on the pressures that exist in the lungs don't worry about these names here, but also what the relaxing pressure in the left heart is. The relaxing pressure in the left heart has to be less than 15 millimeters of mercury. That tells us the left heart is working fine, but the artery pressures in the lungs are very high. And that tells us that the disease is all inside of the lung. And I can talk a little bit more about that later. Currently, it's very controversial what the pulmonary artery pressures are doing with exercise. I see that Cindy is asking if the echo is normal, should the catheterization be done? And this is an area where the controversy is actually continuing to work through research. There are colleagues who are actually taking patients who have what would be considered a normal echocardiogram at rest with scleroderma and putting in a catheter and exercising patients in the cardiac catheterization lab. We do this routinely. It can be done. And looking at what the pressures in the lungs do with exercise. This is one of the initiatives that the Pulmonary Hypertension Association is working on, diagnosing this disease very early. We could certainly miss the disease with an echocardiogram, but it may be that by rest cardiac catheterization or even by exercise, we can pick up early pulmonary hypertension. But I have to tell everyone here that really this is controversial and is done within a clinical trial or clinical investigation frame. Here's a picture of one of our fellows, David Pock. Dr. Pock is now practicing pulmonary hypertension in San Diego. Him and I are in the cath lab performing a heart catheterization on a patient who is laying on the bed. Here's a machine called the fluoro machine, the fluoroscopy machine, that is guiding David and I through the chambers of the heart to the lung. And here you can see someone's heart and the lung out that looks a little bit white because there's air in it. This is a very controlled setting. The right heart catheterization is very safe when done at expert centers. And basically, not to get too technical here, this is what we're looking for. We're looking to make sure there is no intrapulmonary or intracardiac shunts, meaning there is no congenital heart diseases. We're looking to see how your pulmonary hypertension, how the pulmonary circulation and the heart are working. What are the PA pressures? This is what the mean PAP is. What is the left heart relaxation pressures? And how is your cardiac performance? And sometimes we do angiographic procedures where we inject contrast into the lungs and we can see if there is any blood clots there or not. One of the other most important parts in terms of scleroderma is that we can actually give medications in the cardiac catheterization suite to look at the response of the heart and the lung to medications. And certainly that can tell us some information about how your heart and lungs perform. Patients who come and see me know that I do the vasodilator challenge on every visit because I believe it's very informative. But if you have a right heart catheterization, the first right heart catheterization should have a component of vasodilator testing challenge involved in it. So I hope that I've taken you through some of the early diagnostic things, but as this cartoon shows out, we want to make sure we understand how the heart works in pulmonary hypertension. And specifically, as it comes to scleroderma, you may hear imaging tools that are going to be used not as diagnostic, but potentially as evaluation of your cardiac and lung performance. Cardiac MRI is a test that is a magnetic resonance imaging test. It's an MRI test that takes about an hour, and it tells us a little bit more comprehensively than echo about how the heart works. FDG PET is a nuclear study where there is a radioactively labeled glucose that's injected, and we look at how the heart uses that glucose and the sugar, and that tells us the function of the heart. And finally, cardiopulmonary exercise testing is relevant in scleroderma because, as you will see, sometimes we can't simply tell if it's the lungs fibrosis in the lungs or the heart, such as pulmonary hypertension, that is giving symptoms to you as patients. So how do we think about pulmonary hypertension as a whole? This is a very, very busy slide that has just one point to it. What I want you to know is that there are many things that can cause pulmonary hypertension. Pulmonary arterial hypertension is a group 1 diagnosis here. This is called the WHO group. WHO group 1 is pulmonary arterial hypertension, and it's patients who have the hemodynamic definition. Their mean pulmonary artery pressure is greater than 25 millimeters of mercury, but also the wedge pressure, the left heart pressure, is normal. There is no left heart disease. There is no interstitial lung disease. There is no blood clots, and there is not other reasons for people to have pulmonary hypertension. This essentially is the group where all the clinical trials have been done and all the therapies have been applied. As you can see here, connective tissue diseases is where scleroderma resides as a group 1.4 diagnosis. What that means is that scleroderma is associated with pulmonary arterial hypertension. It's estimated that up to 30 or 40% of patients with scleroderma can have pulmonary hypertension. But the most important thing to recognize about scleroderma is that it can also affect the left heart in the way that it works, meaning its pump when it's actively pumping, systolic function, when it's actively relaxing, diastolic function, or how the valves are working. And also, as I will mention in a few minutes, the scleroderma can certainly cause interstitial lung disease. So the most important thing that I do with my scleroderma patients when they come to our clinic is I make sure that we're not dealing with overlap of these diagnoses as well as the heart diagnoses with pulmonary arterial hypertension. There are other diseases that are categorized as pulmonary arterial hypertension. Primary pulmonary hypertension is now referred to as idiopathic. There are some patients who carry a genetic mutation, and the most famous of that is bone morphogenic protein, BMPR2. In California, one of the major reasons that we have pulmonary arterial hypertension is associated with methamphetamines and cocaine. So what I tell my scleroderma patients who I consider at risk for having pulmonary hypertension is to also avoid things that can induce pulmonary hypertension. Smoking cigarettes, using methamphetamine and cocaine, drinking heavily to develop cirrhosis or abnormality of the liver. These are all things that might predilect my scleroderma patients in developing pulmonary hypertension. And if I see a patient who doesn't have pulmonary hypertension yet or pulmonary arterial hypertension, I for sure will let them know to avoid those triggers. Here are the signs and symptoms that I was mentioning to you earlier. A patient with pulmonary hypertension may feel dizzy or may even faint. This is referred to as syncope. Syncope is a dangerous symptom that indicates that the brain is not receiving as much blood as it should. Shortness of breath is the most common presenting sign for pulmonary hypertension, and it has likely been attributed to other diagnoses, especially in young women that we see in clinic. Most of the time, patients are told that they either have asthma or that they don't really have any lung disease. This used to be the case certainly 10 years ago, but we're still finding that that's the case now. Chest pain is a sign that the ventricles are under a lot of stress, and that needs to be evaluated. But sometimes patients present with a variety of very vague symptoms, feeling tired or worn out. These are not very specific to pulmonary hypertension, but it can certainly happen in someone who has scleroderma with or without pulmonary hypertension. One of the common signs of heart failure or right heart failure is swelling of the legs and the ankles. That is for sure one of the signs that we continue to follow as we treat patients, and that should also be a sign that should trigger some degree of investigation in someone who does not have history of pulmonary hypertension. As I mentioned before, early disease, as I showed you in the schematics, is associated with likely less amount of symptoms. For example, a patient who feels very short of breath after 2 flights of stairs is someone who is very, very different who feels short of breath at rest. And we can go through other symptoms here as well. But the most important point that I want to point out to is, as physicians, what we like to do is make a diagnosis of pulmonary hypertension, but also follow the symptoms by classes. A class 2 symptom is an earlier disease symptom than a class 4. And this has a lot of bearing on how we treat patients and how aggressive we are with the therapies that we provide. The difficulty here is, especially in scleroderma, to say that this is all coming from the pulmonary arterial hypertension rather than interstitial lung disease that can have some of the very same symptoms. The most important thing about functional classification is that it's a very good marker of how severe the whole disease spectrum is, but it's not very specific to pulmonary arterial hypertension itself. But if you go to any center who knows how to treat patients with pulmonary hypertension, you can be sure that in your chart there is a class 1, a class 2, class 3, or class 4 labeled at every visit so that the physicians can understand if the therapies they're giving you are helping you or not. This is what, as physicians, we use to understand disease in its entirety. This is what we call a Kaplan-Meier curve. This is a curve of percent survival on the y-axis and years of follow-up on the x-axis. And here you will see a survival curve of someone with, or a group of patients in the 1990s without any PAH-specific therapies over a 5-year period of time. The disease is very devastating. 68% survival at 1 year, but only 34% survival at 5 years. In specific to scleroderma, one might wonder, what does this mean about if I am diagnosed with PAH? What does that mean for me in terms of prognosis? This is data from 2004, again, a Kaplan-Meier curve of percent survival. Everyone starts at 100%, and years of follow-up. The middle line here, the dotted line, is for patients with primary pulmonary hypertension or idiopathic, as I mentioned. But you will notice one of the lines that has a very, very sharp decline is what we call collagen vascular disease or connective tissue disease, basically patients with scleroderma and lupus. It's as aggressive, at least in 2004 when this publication was taken, as HIV was in pulmonary arterial hypertension. So this has been a real focus, and I know that the Scleroderma Research Foundation has focused on this in terms of PAH, and I know that the PAH community has really focused on the fact that we need to understand scleroderma a lot better and approach it very, very aggressively. This is another Kaplan-Meier curve that for now, because of the time, we'll limit our conversations about. But basically, this is the work that Dr. Lorenda Chung and I have done in a large population of patients with systemic sclerosis or scleroderma, showing that having scleroderma is one of the higher risk factors in any of the connective tissue disease spectrums. So we want to be very aggressive once we get the diagnosis of pulmonary hypertension, and we need to be thinking about treatment. As I mentioned to you before, pulmonary arterial hypertension and the vascular complications of scleroderma are not to be thought of by themselves. interstitial lung disease can certainly happen in patients with scleroderma up to 40% of times, and can quickly become a leading cause of morbidity and mortality. These are slices of CT scans, and the dark spots here are the lungs. The light spots here, this is the heart, and this is also structures of the heart. But I wanted to show you what a normal lung looks like. These are the blood vessels of the lungs here on a CAT scan. This is a patient who has early interstitial lung disease. You see the ground glass appearance here. This is someone with scleroderma who has much more advanced lung disease. And finally, this is someone who has what we call UIP, or honeycombing in the lungs. We have to be really careful about diagnosing scleroderma lung disease in terms of the meat of the lungs. Because if we look at, again, prognosis, we know that if a patient has pulmonary hypertension with interstitial lung disease, we have to think of that person as being on a different curve, much more aggressive disease than even PAH, as you know, and this is the way we think about pulmonary hypertension. So, pulmonary disease in scleroderma. So, when you come or when you go to a comprehensive clinic dealing with scleroderma and a clinic who deals with lung disease, we want to know that, make sure that there is no interstitial lung disease like fibrosis. If there is, we have to send you to our colleagues who know about that, how to treat that. We want to make sure that the scleroderma hasn't affected the left heart. And finally, there are gastrointestinal complications of scleroderma. But why are these important? They're important because they identify reasons why we may not have to treat the patient the same way. Certainly, that we may actually make someone feel worse if they have pulmonary hypertension and left heart disease. And often, and sometimes very important for us, if we're thinking about lung or heart transplantation in patients with scleroderma, we have to make sure that we're dealing with the gastrointestinal complications accordingly. I think we have about 10 minutes left, and I'd like to go through some of the therapeutic options that are available and make some general comments. In 2004, Dr. Humbert, who is a close colleague of mine and others, did a very nice review in the New England Journal, showing that there are 3 different pathways that we know how to treat in pulmonary arterial hypertension. Prostacyclin is an agent that dilates the blood vessels of the lungs, and we can infuse it by infusions or give it to you by inhalers. Sometimes we can even think about clinical trials that are using this in a pill form. Nitric oxide is very interesting. It's a gas that promotes dilation and relaxation of the blood vessels. We don't usually like to give that gas as an outpatient to patients because it's very cumbersome and difficult. But what we could do is reduce the breakdown of this gas by giving agents like sildenafil and tadalafil, which are phosphodiesterase inhibitors. And we can also give inducers of this pathway, which is a drug called riociguat, which is currently in clinical trials. An endothelin pathway is a pathway that, when it's activated, causes a lot of constriction of the blood vessels. And we now have endothelin receptor antagonists that block this endothelin-1 from attaching to receptors. And that's a way for us to treat PAH patients as well. This is the timeline of development. In the 1990s, we only had calcium channel blockers, blood thinners, digitalis, and diuretic medications. These are now considered placebo. These are not disease-modifying. In 1995, one of the best things that could have happened to us happened with the advent of infusion epoprostenol. And infusion prostacyclin medications have been approved by the FDA in 2002 and 2004, both into intravenous form and subcutaneous. And now we have inhalations that are approved as well, inhaled iloprost and inhaled treprostinil. Oral endothelin receptor antagonists were approved in 2001 was bosentan, and more recently ambrisentan. And as you already probably know, sildenafil and tadalafil are also approved for the treatment of pulmonary arterial hypertension, which includes patients with systemic sclerosis or scleroderma-associated PAH. Here are those FDA-approved agents listed, but I want to get to some of the specifics. Here are some inhalation devices that you can see. This is an inhalation device used for inhaled iloprost. It's a device where the medication is put into this chamber here and nebulized 6 to 9 times a day. This is an inhalation device for treprostinil, and the patient uses the mouthpiece to use it 4 times a day. Before the inhalation devices were approved, we had intravenous infusions, and we still do. We use it for a lot of our patients where the pump is connected to an intravenous line that is placed either on the right side or the left side that goes and infuses a medication directly into the heart. The medication comes either in vials of powder or liquid and is mixed by the patient or the caregiver, and the pump is set up every 24 hours. It's a complicated device to use, but we've seen it successfully used in patients, and certainly in patients with scleroderma. One of the considerations, though, is the impact of sclerodactyly and digital changes with scleroderma and how patients can interact with pumps. But I have to tell you, when we've had the need for a patient with scleroderma to use it, we have certainly been able to allow that to be used. There are some times that medications don't provide adequate clinical response. And that's when we begin to combine all these medications together, the prostacyclins, the phosphodiesterase inhibitors, and the antagonists. And we usually combine them in a step-up therapy. If you're on one, we don't take one away, we just add another one. But we have to say that this sequential combination therapy is the standard of care in the United States, but it's expert opinion driven. There are no formal clinical trials to show that switching out some of these medications is not effective enough. So there is a lot of debate on how to do this switch therapies. And finally, atrial septostomy and lung transplantation for patients who don't do well with even the combination of these therapies. But before we go there, I want to tell you about investigational therapies. There is a lot of therapies that are investigational. Tammy asked about L-arginine supplementation earlier. L-arginine is certainly continues to be investigational, but it's certainly something that hasn't really been approved, and there are a lot of complicated issues about L-arginine supplementation, and certainly those are sort of under investigation. Oral prostacyclins are currently under investigation. There are other therapies. One is called macitentan, which is an endothelin receptor antagonist that has recently been trialed and has had a successful finding in its clinical trial. They'll hopefully be going to the FDA soon. But what you'll see is numerous other avenues of therapy. We don't believe that those 3 pathways are the only 3 pathways. As a matter of fact, maybe those 3 pathways are not all important for scleroderma-associated PAH. I can tell you about rituximab in a second, but recently there was a chemotherapeutic agent, Gleevec, that was trialed and currently being refined in this investigation. Stem cell transplant clinical trials are underway in Canada and will soon be underway in the United States. The rituximab trial for systemic sclerosis-associated PAH is a trial that is currently enrolling. It is one of the only, if not the only, NIH-sponsored trial that we are participating in, and it's only for systemic sclerosis-associated PAH. I urge you to consider it if you're inclined to do so. So finally, I want to use the last 2 slides towards factors for you as a scleroderma population to consider when you're choosing therapies with your physician. There are mechanistic reasons why endothelin receptor antagonists may have an advantage in scleroderma. There are some long-term data in our registries that show that there is a very unique effect from endothelin receptor antagonists, anti-proliferative effects that these agents have in scleroderma. We know that some of these agents actually can treat digital ulcers, and so we think that there's a mechanistic link here, and there is probably more reasons to use ERAs in scleroderma and autoimmune diseases. You may already know that sildenafil or Viagra and tadalafil can treat Raynaud's phenomenon pretty well, and that may be a reason for us to consider using these sort of therapies. But at the same time, I want to caution you that because scleroderma has associated left heart disease and interstitial lung disease, some of our therapies may make you feel worse. And while it's important to tell your physician if you're feeling well on these medications, it's even more important for you to tell your physician if you're not feeling better. Or if you are actually feeling worse, not side effect wise, but if you feel your exercise tolerance, your oxygen requirements, all of that have declined with the therapies that we've given you. So the take-home message that I wanted to make sure to come through to you is there are many pulmonary complications of scleroderma that are currently very important to manage and diagnose appropriately. I personally feel that multidisciplinary approach is very, very important in the best care and comprehensive care of pulmonary hypertension, but also of lung diseases and scleroderma. I think that it's important that you ask some very important questions about your pulmonary disease or pulmonary hypertension from your specialists, whether they're pulmonologists, rheumatologists, or cardiologists. Do I really have pulmonary hypertension? Have you done a cardiac catheterization to show me that? Do I really have interstitial lung disease? And do I have left heart disease? And I can tell you, please, please, please don't forget those cutting-edge clinical trials that are out there to provide help. So with that, I really want to take a moment to thank Luke and the Scleroderma Research Foundation for having me, but also want to tell you that we have a big group of both clinical researchers and clinical care physicians and staff that are here to dedicated themselves to taking care of patients like you. Thank you very much.
That's really great, Roham, and fantastic presentation. We've got 12, 13 minutes left to take a few questions from the audience, and I'm just going to try and lead off and try and get people thinking. One of them is, I was under the impression, and you alluded to it, but I wonder if it's worth discussing in a little more detail about the Phase 3 design and the results that came out of the macitentan trial, which at least my understanding was it was really the first time that we've trialed the endothelin receptor antagonist class with a morbidity and mortality endpoint. Is that right? And do you want to talk a little bit about that?
Absolutely. I think that the most important thing to realize is that how are we going to really understand the therapies that are most impactful? The most important thing I think about the macitentan study is the fact that it is a study to look at how the medication impacts outcomes. And that's never been done. It's done in patients with left heart disease and coronary artery disease because predominantly that those are very, very large population of patients. But with PAH in general, and certainly scleroderma-associated PAH, very narrow amount of patients available. So this trial was done as a global trial. It was done over several years' time, but it was a morbidity and mortality driven. And it's important to physicians, and I think it's important to patients, because the clinical trials that have been done so far have been approved on the basis that they improve 6-minute walking distance. 6-minute walking distance is marred in a lot of controversy, certainly in patients with joint disease and skin disease, such as scleroderma. And so, yes, I think it's a very important trial. I think it's very meaningful. I think when we think back and think about other medications like bosentan and ambrisentan, we don't have the data what they would have done if they were part of the similar design of study. So the design is very novel, and probably that's the design that's going to come down the line from a lot of other therapies. I hope that answers your question, Luke.
That's great. Thank you. I don't see any questions on my screen, so let me keep going. And you've talked extensively, but I thought maybe we just have a slightly more open discussion about why scleroderma patients don't seem to do as well. Do you think that there's a mixture in those clinical trials of patients who actually have some fibrosis, or do you think that the vascular disease that scleroderma patients get as compared to primary PAH patients, is that vascular disease different?
Yes, I think that both of those points are very correct. I think I can tell you, I have a clinical trial that I've been running specifically myself. It's not important with that clinical trials, but I had a scleroderma gentleman in it, and halfway through the trial, we recognized that he had substantial interstitial lung disease. Not that he didn't have it before, but I think it developed and progressed so much rapidly that it became very, very important in the middle of the clinical trial. So I think that's one thing. The complexity of scleroderma as it affects different organs, such as the lungs, such as the heart, such as the kidneys and the liver. That, I think, is one part of it. And then the second real part of it is essentially that we know that things such as the way that the heart relaxes and works, and the neurohormonal environment, and this is heavily loaded, but basically we understand that there is something that is vascular in nature beyond what pulmonary arterial hypertension is. My personal feeling, and I think that if you look at the literature, Lori and I have shown this, is that scleroderma-associated PAH patients in their heart catheterization numbers, it looks like a very favorable finding. The severity of the disease by heart catheterization is not as severe as it would seem for idiopathic patients. But there is something that we're not really measuring. There is some vascular component that I think that is missed there. So I think that that's what it is, Luke. I think it's a multifactorial and not just a pulmonary specific disease, and that's what I think it leads to the complicated rates of it. And the argument is, and others at major centers in the U.S. would say that it isn't just correct to assume that we have to treat pulmonary arterial hypertension and scleroderma with a bunch of just PAH medications. It's basically that those PAH medications are not always the end-all in how we treat the disease. Maybe the way we modify the disease, we address the autoimmune nature of it, and that's why I think that the rituximab study is very important.
Yeah, actually, why don't we take a second and talk a little bit about the rationale behind that study, Roham, because I think it's a very interesting approach. I know you've alluded to the fact that there is a trial that's now open, but maybe we could talk a little bit more about the rationale and have a second to discuss why you're in the middle of it.
Absolutely. So I think that without getting very complicated, and I'm also not an immunologist, so I at this point can't get very complicated for you, but the idea is that there is a population of the immune cells that are responsible for the vascular injury that's caused by systemic sclerosis and scleroderma. And number one, the idea of this study was, can we identify this population of cells to be the population that rituximab, which is a monoclonal antibody, addresses? And the second issue is that if we knock out these cells that are causing the vascular injury, can we improve pulmonary hypertension? And that's really the rationale of the clinical study. So the clinical study says we are asking for patients who have scleroderma-associated pulmonary arterial hypertension that has been diagnosed the appropriate way, very minimal, but if some fibrosis exists in the lung, that's fine. We'll take those patients, and what we do is a baseline heart catheterization to see where their numbers are and how the patient is feeling, how they perform on a walk test, and a subgroup of those patients in our own study we'll be doing through a cardiac MRI. We give the infusion of this medication, and we look for tolerability of the infusion. Obviously, so far the patients that we have enrolled have tolerated it beautifully. You get 2 infusions in a matter of a month up front, and then we come back 6 months later and do another heart catheterization and see how the pressures have changed, if they have changed, how the heart function has improved, if that has improved. As you know, a clinical trial, the most appropriate way to do it is it has to be blinded to what therapy you get. So in this case, it's placebo, and it's blinded, so that one group of patients get saline or just an infusion, and another group actually get the medication. And that's the only way that we can logistically provide clean clinical data. But we're hoping that we can wrap up and enroll this trial very quickly so that we can get some very important information out.
I do have a couple questions now from our listeners. Let me just pass those along. One's a very practical question. I think you've gone over this in a little bit of detail, but maybe just to review. When a patient is diagnosed with PAH, what further follow-up questions should they be asking their clinician, and what do they need to know, perhaps before they start to take, before they decide on some therapeutic options?
Yes, I think that's very important. I think basically they need to know, first of all, how exactly is the diagnosis been reached, and what is the interaction between this diagnosis and others if they have that diagnosis. The second thing is that basically I personally believe education is power, and what we try to do is empower our patients with PAH to read about the different therapies that are available. The reality at the end of the day is some therapies that are very aggressive, which are the intravenous prostacyclins, also have a whole host of side effects. And I know that scares patients away from those therapies. I think the patients should ask a risk and benefit kind of question from their physician. So if I walk in and I accept the side effects that this drug will provide for me for sure, what do you think are the benefits that I get out of it on the other end? And I have to tell you, in a PAH spectrum as a whole, we know that intravenous prostacyclins achieve the best results. Now, that's a little bit complicated than scleroderma, but certainly I've treated patients with scleroderma very successfully with infusion therapy. So I think that the patients need to ask their physicians some of the hard questions. What am I going to get out of this? And then I think the other question that I think patients really need to ask and engage in is what am I looking forward to? Recently I lost a very, very close patient of mine to scleroderma and PAH, and at the end the conversation was, I want to have a quality of life. I don't want to have these episodes of pain and shortness of breath. And we talked about palliative care. So I think that one of the important things that sometimes gets ignored in a very busy clinical office, and sometimes maybe physicians are shy to address, is prognosis and what is it that the physician needs to hear from the patient, what it is that the patient wants. If it's the quality of life that the patient wants, sometimes our therapies are not very good at promoting quality of life. So I hope that sort of answers that question, but there are a lot of different things that I think is considered how engaged the patient is with their physician, and they should expect the physician to be as engaged with them and give them straightforward, honest answers. And if they don't get that, I think it's time to find another physician.
That's great. That's a really thoughtful answer. Thanks, Roham. And let me just summarize, if I may. We're just about out of time. So, and just to conclude and remind everyone, so Dr. Zamanian is the director of the Adult Pulmonary Hypertension Clinic at Stanford, and he's also the assistant professor of medicine at the Stanford School of Medicine. And in closing, I'd like to remind you about the Scleroderma Research Foundation and what we're trying to do. So when you close the webinar window, you can provide valuable information to us and to the community by completing the short survey. And of course, please visit us online at www.sclerodermaresearch.org. Recall, any gifts from now through the middle of November, November 12th, will be matched dollar for dollar. I'd also like to thank our sponsors, Gilead and MedImmune today, who provided some invaluable support for our webinar series. Thank you all for attending, and we look forward to seeing you again in the future. Bye-bye for now.
Bye.